We are going to get started. Welcome everyone to the Trauma-Informed Care in Reproductive and Sexual Health webinar hosted by HCET with our Midwest Trauma-Informed Training Center and our presenter, Dr. Kara Berg-Ronick. My name is Megan Arias. I'm the Training and Organizational Development Manager here at HCET, and I'll be moderating the webinar today. So I want to just briefly touch base on what HCET or Healthcare Education and Training is. At HCET, our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And we're an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. Next slide, please, Kara. So this webinar should have closed captionings available. I believe Dr. Berg-Ronick has them on her PowerPoint themselves, but if not, there should be a button at the bottom. If you hover over your screen and click live transcripts, it should be able to show subtitles from there. Next slide, please. And then if you have any questions throughout the presentation, we encourage you to submit those via the Q&A box. And again, that will be at the bottom of your screen. So if you hover over that main screen, there should be a Q&A box at the bottom. We encourage you to use that versus the chat, as through Q&A, you can ask a question anonymously if you would like to. And we'll hold all questions till the end during that dedicated Q&A time. Next slide. Thank you. And then please be sure to follow us on various social media platforms and accounts to keep up to date with the newest information and events. And just a little disclosure, our website is currently being renovated and it should be back up to speed in the next few weeks. So it may be a bit confusing, but if you have any questions, just reach out to any one of HCET's staff members. Okay, and then just a quick bit of housekeeping. A link to complete the event evaluation for this event will be sent to you in the chat at the end of this webinar, as well as in a follow-up email that you should be receiving later this afternoon. And you can find a list of archived presentations and a list of upcoming presentations on our website. And if you have any technical difficulties during this presentation, please reach out to updates@hcet.org, and we will be sure to get everything sorted for you. Next slide. Thank you. So in order to receive nursing contact hours for this presentation, you must attend the entire webinar, return the completed participant evaluation post-test, which is in the evaluation, and then complete the nursing contact hour form and email it to the email provided on your screen. And if you are wanting nursing contact hours, all of this information will be in that follow-up email, so no need to scramble and write everything down in terms of emails and things like that. The forms and who it should be sent to will be in that follow-up. Next slide, please. Thank you. No one with the ability to control the content of this activity has a relevant financial relationship to disclose with an ineligible company. Next slide. Thank you. So now I'd like to introduce our presenter for today. Dr. Kara Berg-Ronick, a nurse practitioner, is the Director of Clinical Quality at Healthcare Education and Training, where her work focuses on improving reproductive and sexual health and adolescent health outcomes throughout the Midwest, and where she is honored to serve as the director of HCET's newly launched Midwest Trauma-Informed Training Center. She maintains a clinical practice through Path for You, Indiana's statewide contraceptive access project. Using and advocating a trauma-informed approach has been central to her philosophy of care since early in her career, when she worked as a certified sexual assault nurse examiner at the Cleveland Clinic. Kara is a past president of the Indiana chapter of the International Association for Forensic Nurses and currently serves as the lead for the Indiana Paternal Quality Improvement Collaborative's Trauma-Informed Care Subcommittee. She teaches frequently in the community, academic and professional settings on various sexual health and trauma-informed care topics. So without further ado, I will pass it over to Kara.
Thanks so much, Megan. Hi, everyone. It's nice to see you and some familiar faces, including somewhere one of my childhood best friends is on. So that's awesome. So happy to be presenting the official first webinar of the Midwest Trauma Informed Training Center. So HCT, in response to community need, launched MTITC with a goal of making in-person and virtual trainings, resources, and technical assistance in trauma-informed care available to healthcare providers across the Midwest. Our goal really is to transform the landscape of health and human services by helping to equip professionals with the knowledge, skills, and support to provide trauma-informed care as standard practice for all. To learn more or to partner with us or stay updated as we continue our rollout, you can email updates@hcet.org. And at the end of the presentation, there'll also be a QR code that takes you right to the sign-up list. I also want to just acknowledge and appreciate that funding for this webinar was provided by the Indiana Department of Administration on behalf of the Indiana Family and Social Services Administration for Hoosier Families First Fund Maternal Child Health Programming. So thank you to them. Okay, while we look at our objectives for a moment, I want to pause before we go any further and just say that I hope that you will do what you need to do to take care of yourselves throughout the session. It may be sort of obvious given the title of the talk and the fact that we're talking about trauma and trauma-informed care, that we'll be discussing some harder and potentially activating topics today. Do whatever it is that you need to do, whether that's take a step away and come back to the recording, be video off, whatever it is that you need to do. I encourage you to take that space. So to begin a talk on trauma-informed care, we have to begin with some shared understanding and definitions, knowing that there are people in the room who maybe this is your first exposure to the idea of trauma-informed care, and there are also people in this room that I know could be giving this lecture instead of me. So we'll do a little bit of level setting and then dive a little bit deeper. So trauma can be defined in many, many ways, but SAMHSA, which is the Substance Abuse and Mental Health Services Administration, defines it as something that results from an event or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting effects on an individual's functioning and well-being. So you'll notice here the highlighted words, those 3 E's of trauma: events, experience, and effects. So if we take those E's one by one, we'll notice that experience is key. It is really the individual that decides if an experience is traumatic or not. The same event can be experienced by one person as traumatic, that for another is run-of-the-mill or not traumatic. So again, my clinical background is in GYN, started my career at the Family Maternity Center, and one example in our world could be the experience of a cesarean section, right? Where for one person, it's just one of the ways a baby comes out, right? Where for another, it is it may be even actually a preferred option, right? That this is something that allows them to schedule when their sister or mom comes and stays with them, allows them to plan their last day of work. It's really the choice that they want and empowers them. And then for yet another person, a C-section could really be viewed as a failure of their body, of who they are, and really be experienced as a significant trauma. Okay, so again, same event, but experienced and defined very differently. Another example in our sexual and reproductive health world could be a new diagnosis of HIV, right? So maybe one person is really aware of treatment options, understands U equals U, right? Undetectable equals untransferable or untransmittable, knows people in the community who have lived robust and long lives with HIV. And so while it means new medical care, and maybe that isn't desired, they know how to manage, how to cope, and they feel supported. Sorry, my office is downtown and there's a bunch of sirens going by, I apologize. So for that person, it is not traumatic. It's something they can take in stride. We've even heard stories of folks who actually experience relief with a diagnosis of HIV because now they can manage it and not live in sort of a state of anxiety or wondering or waiting. And then for others, we have likely all, if we've worked in this field, seen people for whom the diagnosis is truly devastating and a trauma on its own. So types of trauma, if we talk about events, can be broken down into additional categories. So some types of trauma are acute. So this is things like a one-time event or a natural disaster, like a one-time sexual assault. And by the way, I would invite you, if you'd like to go ahead and add additional examples that you feel like I'm not covering here into the chat so that other people can benefit from your experience and thoughts. So again, could be something that's a disaster, a one-time sexual assault, something like that. Can also be things that are chronic or complex, which could be things like witnessing or experiencing domestic violence in the home, loving someone or living yourself with substance use disorder, experiencing human trafficking, living unhoused. There are a great many things. So traumatic experiences can primarily affect one individual, but it can also extend to their families. So maybe something like a car accident or a severe illness, right, impacts not only the individual, but also the people in the circle around them. It also can occur in the context of a group. So here we might be thinking about maybe something like trauma experienced by first responders or folks in military combat. It can also happen in a community as a whole, like, for example, gang-related shootings that can really rock a neighborhood or a city or community to its core. It could also happen within a culture. So we could think about examples we've seen of a mass shooting at a synagogue or a queer bar or something like that. And then, of course, it can also be a large-scale disaster that impacts perhaps an entire country. So hurricane, war, terrorist attack, things like that. Okay. I also want to spend a few minutes talking about historical trauma. So historical trauma reflects systematic and systemic oppression of a particular group across generations. So examples we hear often here are things like genocide, slavery, police brutality, forced relocation. I myself am the grandchild of Holocaust survivors, and we certainly feel this historical trauma within my family. So because we're talking specifically about reproductive and sexual health, there are infinite examples that we can give in this space specifically that help us to understand how our patients or clients are really bringing a well-earned historical mistrust of the healthcare system into our interactions with them. So in gynecology, we have some really specific examples, such as maybe you've heard of J. Marion Sims, who was considered the father of gynecology. He even had this statue erected in his honor in New York City. It has since been removed. But Sims contributed some major things to the field. He invented the speculum, developed surgical techniques that are still used in modern medicine. But he did this by experimenting on enslaved Black women. You may have seen this painting before. This shows Dr. Sims and Anarcha. She was an enslaved woman who was just 17 when she had her first baby, and he performed 30 non-consensual surgeries on her. He did not use anesthesia, even though it was recently available at the time. And at the time, people believed that Black women did not feel pain as much as their white counterparts. And in fact, this myth still presents today. We know that it is well documented in the medical literature that Black people receive statistically less pain medication than white people during hospitalizations and after surgeries, again, persistent today. So this legacy continues with historical and intergenerational trauma in our society with, frankly, more examples than we can count. So we can think about Henrietta Lacks, who was a Black woman who in 1951 had her cells taken during cancer treatment without her knowledge or consent for use in medical research. We can think about the history of the pill, where clinical trials were done in the 1950s on Puerto Rican women without being told that they were participating in a trial or about any of the potential risks involved. We can also look at our country's history of, as well as ongoing instances of coerced and involuntary sterilization. And then to what I think is often the quintessential example for many people, what comes to mind, of Tuskegee, right? Where Black men were followed for over 40 years, from 1932 to 1972, without treatment to see the progression of syphilis without their consent. And this went on well after treatment for syphilis was available. And y'all, 1972 just is not that long ago. This is very much a part of our current cultural conscious and things that our patients or their immediate relatives may have experienced. So we can understand, looking at this kind of horrific collage on the screen, that all of this has sown distrust in our system. Systems level trauma and historical trauma enters our encounters every single day in healthcare and in life. Okay, so we've talked about experiences and events. Let's talk for a minute about the effects. Hopefully many of you have heard of the ACEs study, and if not, this is your official invitation to go learn more. I always say if anyone is in school and you need to find a journal article to do something on, find something on the ACE study so you can learn more about it. So the deal is that in 1998, Kaiser Permanente and the CDC did a major study with over 17,000 participants, so just enormous, looking at 10 categories of adverse childhood experiences. And what they found is that living through these 10 types of adversity can lead to an increased likelihood of multiple types of adverse health outcomes. And they found a dose-response relationship, that the more ACEs a child had experienced, the more likely they were to experience these outcomes. You'll notice a couple of interesting things. It's not about how many times someone experienced these or how severe they were, right? But just kind of a yes, no, plus, minus, did this happen or not, about experiencing the categories. Another important thing to note about this study that we just have to own as a limitation of the original data is that participants in this study were largely white, largely middle class, and highly educated. A more recent Philadelphia ACE study focused on a more diverse and urban population, and it also focused on community level adversity versus simply personal adversity, and how that also could impact health outcomes. So ultimately, they found additional 5 ACE categories that are noted here. So living in foster care, feeling discriminated against, experiencing bullying, witnessing violence, and experiencing adverse neighborhood experiences. We know that ACEs are incredibly common. From just the original 10, not even including the expanded definition, we know that 64% of people have experienced at least one ACE, and 12.5% have 4 or more ACEs. So what kinds of health outcomes are we talking about? Well, there are many. People who have experienced 4 or more ACEs are 12 times more likely to have attempted suicide. They are 7 times more likely to have an alcohol use disorder and 10 times more likely to have injected street drugs. Also, many of the top causes of pregnancy-associated deaths are directly linked to ACEs, to higher ACE scores, including accidental overdose. It's important to recognize, though, that it's not just things that could be considered coping mechanisms, right? We're talking about alcohol use disorder, overdose, things like that. It's not just things that could be considered coping mechanisms or mental health concerns, right? It can be easy to draw the connection of you experience these ACEs and you have a higher likelihood of experiencing anxiety, depression, PTSD. There are also things that don't have such a clear connection. So ACEs are also associated with higher rates of diabetes, of cancer, of heart disease, and more. There was even a study out of Wales done in the last year or so that showed that the higher someone's ACE score, the more likely they were to decline to get the COVID vaccine. So this has big implications for public health across many, many, many domains. ACEs can have long-lasting negative impacts on our health, again, across many, many domains. Why is that? One of the proposed mechanisms is through the concept of toxic stress. So we know that not all stress is bad, right? Some stress is healthy and positive. It prepares us for the temporary challenges we face in our lives. So things like running a race, starting a new job, giving a presentation. When these things occur, our stress response activates, and then it quickly returns to baseline. More intense and longer lasting stressors can be tolerable, even if they're more significant and sort of negative things can still be tolerable if we have support systems in place in our lives to help us cope. If we don't have those supports or coping mechanisms, severe or frequent exposure and certain types of stress can have what truly is toxic effects on the body and brain. So Dr. Nadine Burke-Harris, who is California's first Surgeon General, has a wonderful analogy for when positive stress and even tolerable stress can become toxic. You may have seen her talk about this in a brilliant TED Talk, and if you haven't watched that yet, I'd encourage you to look at Nadine Burke-Harris TED Talk and ACEs. So here's her great example. Imagine that you're walking through a forest. It's a beautiful day, everything is fine, and you come upon a bear. Your body has a reaction in that moment, right? It is your fight or flight response. When you have that response, it can be really protective, right? It can save your life. You are either going to fight that bear, you're going to run from that bear. I, by the way, am clearly going to die by this bear because I am neither going to run from this bear or like be able to manage this very well. But hopefully you have better skill set than I do, and you run or you freeze or you fight, right? However, so sorry, let me go back. So you have that response, you survive this bear encounter, and you go back to your village or your home, and you tell people your story, and you share it, and your community supports you, and you tell the story, and you feel the stress hormones flood off of you. You get a really good night's sleep. You still can have some physical reactions, but this goes away because it was temporary. But what'll have you imagine quickly is what happens if this bear follows you home and moves in with you, right? What reaction do you have now? What happens in your brain and your body when you're faced with that level of stress every single day with no reprieve? Our bodies just simply are not built to be in fight or flight all the time. So we actually experience brain changes when this occurs and when that bear is living in your house, so to speak, right? So sustained activation of the body's stress response physically impacts the brain's functions. There's a pathway in the brain that secretes hormones that actually becomes dysregulated. And this also causes the part of the brain that regulates memory and learning to actually shrink. So it becomes harder to especially sort of collate or synthesize memories of the traumatic event itself, which can be part of why trauma memories are very scattered, right? But also longer term, the part of the brain that functions with learning actually shrinks. The area of the brain that regulates thoughts and emotions also shrinks, and the part of the brain that connects emotions to many other brain abilities, including memory, learning, and our senses, gets bigger. Okay, so now emotional processing can be sort of disproportionate, okay, without sort of the normal controls that are in place. The part of the brain that takes in information from experiences and turns that into how we understand the relevance of situations and how to respond appropriately also begins to lose its ability to respond. You add in those stress hormones like cortisol and adrenaline from the chronically activated fight or flight response, and the stress, and what you get is inflammation, which contributes to all manners of ill health. And that's, again, one of the proposed mechanisms of the connection of ACEs to these ill health outcomes later on. So these brain changes can also impact how we view the world, and how we function in the world. How we build or struggle to build trust, for example. Trust is one of the schemas in the brain that can really be altered by trauma. So since these changes can manifest in a lower ability to regulate behavior and control expression of emotions, you can think about if you've ever had a patient or even a coworker respond in a way that is unpredictable or unexpected to a major or even a commonplace event. Behaviors may appear impulsive or out of control. So this is absolutely something to keep in mind during healthcare visits or when discussing exposure to an STI or a new diagnosis or something like that, that scripts and norms may simply be out the window, okay? Have you ever looked at someone and honestly thought any of these words? Have you ever been called any of these words? The next time that you look at someone or even look at yourself and think some of these words, think about what might be going on behind the scenes and if there are pieces of trauma that might be impacting how these things are presenting. Okay, I've mentioned coping mechanisms a few times. Coping mechanisms are really personalized strategies that allow people to function in their daily lives in the face of past or ongoing trauma, okay? They certainly can appear dysfunctional or maladaptive to the outside. Ultimately, though, they're perceived by the person using them to facilitate their survival. It's important to remember that people aren't always conscious that these activities are in fact coping mechanisms. So again, this is just a way to reframe some things that can sometimes feel frustrating when we see them in our loved ones or in clients or patients. Some of the things we see are self-medicating with substances, sort of a reclaiming sexuality, dissociation, self-harm, and significant or disproportionate anger and aggression. Okay. Please do, again, go ahead and use the Q&A function and all of that if you have things to contribute. Okay, so let's move on, switch gears a little bit and talk about activators. So many people may be used to language calling these triggers, but there's sort of a movement to move away from that language, both because it's associated with a language of violence, right? To trigger means to fire a weapon, and also because being triggered has sort of just become a stigmatized term, right? That can be sort of made fun of in an inappropriate way. So there's a movement to use the term activation instead. So when someone is feeling activated, they can feel extreme distress that is similar to what was felt at the time of initial trauma. They can also have a physical reaction that might mimic that initial trauma. So someone might vomit or dissociate, and you might not even be aware of the sound or smell or anything else that activated them, because you notice, as it says on the slide, the activators can be conscious or subconscious. They can come in through all five senses. So maybe it is the song that is playing in your office as white noise, right? To help with sound between rooms, right? You have the radio playing, thinking that's a nice thing, but maybe the song that's playing is activating for someone. Maybe it was a cologne that they smelled in the waiting room, right? That could have activated them. So again, they may not be aware of what had them in this activated state, and you also may not either, because they are so personalized. Both people's trauma being so individual and the things that can activate someone are so personal, that it can be very hard to predict what those things can be. We have to remember that this can not only happen for the patient or client, but they can also occur for us and for our staff, right? So understanding how common and ubiquitous trauma is, when we think back to that kind of first slide where we talked about all the different types of trauma, we have to assume that those we work with and even we ourselves may have experienced some trauma, adversity, and ACEs, and can carry certain traumas and activators into our interactions as well. One of the biggest and hardest jobs that we have as providers and people who care for others is to figure out how to remain regulated in the presence of someone who is dysregulated, and to figure out how to calm ourselves again when we're faced with an activator in our work environment. This is a little bit of a spoiler alert, but in a few months, and we've got the date on a later slide, we're actually going to be having a webinar on kind of mind-body medicine that's going to talk about how can we work to stay activated, or excuse me, to stay regulated ourselves, and also to help our patients or clients when they themselves are activated. So let's move on to talk about trauma-informed care. I'm just giving myself a little time check here. Okay. So SAMHSA, again, the Substance Abuse and Mental Health Services Administration, defines a trauma-informed approach utilizing the 4 R's. So trauma-informed approach is one that realizes the widespread impact of trauma and understands potential paths to recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, as well as seeks to both actively resist re-traumatization and the creation of new trauma through the healthcare experience. So what does this actually mean? Trauma-informed care is a whole person approach to healthcare that acknowledges the impact of trauma on health and is inherently patient-centered. A trauma-informed framework assumes that trauma is pervasive and that medical evaluation and treatment themselves may be potentially traumatizing. We do this through a whole bunch of tools and techniques that we're going to get into more, but it really emphasizes creating a physically and emotionally safe environment for those who have experienced trauma to help rebuild their sense of control and empowerment during interactions. Okay. It acknowledges that a patient's life experiences will impact their perspectives when engaging with the healthcare system, and that awareness of these experiences has the potential to improve not only patient engagement and treatment adherence, as well as health outcomes, but also provider and staff wellness. It's also important to lift up that disclosure of past trauma is not a requirement to provide trauma-informed care, nor is being prepared to provide trauma-specific services. We are not asking you to be an expert in trauma, just to have an awareness of the ways that this can play in to offer this type of approach. We have to recognize that all people, regardless of a known history of trauma, will benefit from trauma-informed care. I'm going to play a quick video that shows sort of a good overview of trauma-informed care and adverse childhood experiences, and also introduces what really is the key paradigm shift to trauma-informed care, which is the thinking, the shift in our thinking from saying what is wrong with you to saying what happened to you. So here we go with the video. Megan,
You know the old
thumbs up
saying,
video.
don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
All right. So I just think that's a great kind of synopsis. Okay, so we've covered this paradigm shift, and this again is that quintessential change of looking at someone and instead of thinking, "What is wrong with you?" thinking, "What happened to you?" Again, due to the ubiquity of trauma and the desire to not create new trauma in any setting, a trauma-informed approach needs to be viewed through the lens of a universal precautions model. So we think about this the same way that we in medicine think about bloodborne pathogens, right? We don't wait for labs to come back to don our gloves. We just assume that anyone we interact with could have a bloodborne illness, and we treat everyone like this universally. It is not enough to use a trauma-informed approach just with some special subsets of our patients or clients, like those we know have a history of sexual assault, for example, or for someone's first pelvic exam, right? Again, it's a paradigm shift for everyone. Instead of sitting in an attitude of judgment, moving to a posture of curiosity and compassion. Okay, remembering that no one owes us a disclosure and everyone deserves this care. When I say everyone, I want to again be clear that it is not just our patients. It can be our colleagues and coworkers. It can be our friends and family. I truly believe that if we use this approach as we walk through the world every day, we would change the world. We would change our communities. We would change everything. And finally, again, it also impacts you, right? So there's a concept of vicarious trauma, which basically says that someone's worldview can change based on repeated exposure and empathetic engagement with others' narratives of trauma. So even if you yourself have never experienced a trauma personally, just by engaging the way that we do with our patients and clients, we can experience some of the same changes to our brains that people experience from directly experiencing that trauma. Okay. And again, this can change the way we view the world, view other people, and view ourselves. So we talked about the 4 R's earlier. I want to spend a few moments talking about SAMHSA's 6 key principles of trauma-informed care. Before I go any further, I want to take a minute and say that while each of you has an important role to play, and while I just said I believe that each of us doing this can change the world, It is not all on our shoulders. And this is really important to me, okay? The same way that we can't fix the world just through self-care, we need community care and institutional care. It's similar here, right? These concepts are designed with organizations in mind, not for you to shoulder all on your own, okay? A whole environment can't be trauma informed just by your interactions or your changes, although you can be the catalyst and you can make a difference, right? It needs large scale buy-in for that type of change, okay? So when we think about the first key principle is safety. So safety can be really difficult to regain for many people after a traumatic experience. This needs to be, again, not only physical safety, but also emotional and psychological safety. And really that needs to be defined by the people that we're serving. Now, again, lifting up that is not only patients or clients, but also the people doing the work. We all have to feel safe, right? Sometimes this can be challenging because sometimes physical safety and psychological safety can be different, and sometimes they can be perceived differently by different people around us, right? So I think one example for anyone who's ever worked or had an inpatient stay, you know, an example can be bed rails, right? On a bed, we know that we are preventing falls risk and, you know, exacerbation if someone had a seizure, things like this, right? But for someone who has an experience where they are activated by feeling trapped or like they can't move freely, maybe bed rails actually lower their safety. Another example that I think really resonates for a lot of people, especially folks from marginalized communities, is the presence of security or police officers in a space. For some, that is the ultimate symbol of safety and of protection. And for others, just that presence can make them feel unsafe. So as with everything, there are not clean cut and straightforward answers to all of this, but these are all things that we need to start exploring, ideally with, not just ideally, like mandatorily with feedback from the people that we are engaging and caring for, right? When we think about trust and transparency, this means that all decisions are conducted with transparency, right? We're building and maintaining trust with clients, even when we understand that that can be harder to do when someone has experienced trauma. One way we can do this, especially in the world of sexual and reproductive health, is to really discuss what information we'll review with them and why. Okay, we can let people know that we're going to be collecting some really sensitive information before asking them. Remembering that this is totally routine for us to be talking about oral, anal, vaginal sex and which body parts and all these things, but that is not standard fare for most people, right? So explaining the why before we do it can be really helpful in building that trust and transparency and helping people not feel like we're just being invasive for invasion's sake, okay? Peer support is the third concept. And this is really a key vehicle to build safety and hope and trust and enhance collaboration. So peers are people with shared experiences who have survived trauma or other similar adverse events. So this is folks who can use their stories and lived experiences to help promote healing and provide hope. We see this often in public health in things like peer counseling and substance use disorder treatment or in HIV care, right? In the world of reproductive health, perhaps a support group around infertility or infant loss, things like that, okay? It's also important to remember that this applies to your teams as well, okay? Peer support and debriefing needs to be a normalized part of what we do with time dedicated to it. This is not just we're going for drinks after work on our own time when we could be doing a hobby or unwinding at home or with family, although do get together with your coworkers if that is something that makes you happy, right? But this is something that is an important part of workforce maintenance to say, hey, we had a hard day. Let's unpack this together. It's not a weakness and it's something we're going to carve paid and established time for, okay? That's a big culture change for a lot of organizations. Collaboration is key, okay? A main goal in this space is leveling power differences between you and the folks that you're working with. This is often done through shared decision-making or patient or client-led care, okay? Empowerment is when we focus on the strengths of the people that are in front of us, Okay. This could be focusing on the strengths of your teammates, right? Each nurse, each medical assistant, each provider is not all the same, right? We all have things that we can bring, and finding ways to lift that up is really, really valuable to people feeling, again, empowered and valued as an individual. This is also true, again, with our patients, where we are thinking about how incredibly resilient they are and what good they bring into the space, because it for any person inevitably is there, right? This also involves choice, okay? Goal setting when developing a plan of action. Your priorities may not be their priorities, right? And that's okay. That has to be established together and worked through. And then cultural, historical, and gender issues. Here we're talking about, as we discussed, the awareness of the potential for historical and racialized trauma, but also working hard on yourself to avoid stereotypes and biases, to offer access to gender responsive services, and all other elements around this that truly could be its own training, of course, okay? So let's focus a little more specifically in the world of reproductive and sexual health now that we've really gotten our basics down well. So many components of sexual and reproductive health care are impacted by the experience of trauma and adversity in ACEs. So we see folks who have an earlier sexual debut. Again, this is association, not guarantee, right? Just a higher likelihood. And certainly people who have some of these factors have not experienced trauma, right? All of those hopefully common sense disclosures and disclaimers on this slide, right? We do see an association with earlier sexual debut, people having more partners, having more unprotected sex, perhaps adolescent involvement in pregnancies, involvement in human trafficking, substance use, and then, of course, as we've discussed a bit already, fetal mortality and adverse pregnancy outcomes. We also have to acknowledge that these folks can be difficult clients, right? Big air quotes, right? Sometimes termed our frequent flyers, right? And other sort of kind of disparaging language. So I'd encourage us to sort of look at that a little bit. But what I'm really getting at is the people where our best efforts to support and help and guide them and work with them just seems to fall short. And it's natural that this can be frustrating, right? When you've gone above and beyond with your time, with giving of yourself, and then you turn around and find that they haven't followed your good advice, right? Or put themselves back in the same position, are like terms that we hear a lot. We have to remember that those are the most important moments to practice our paradigm shift, not what's wrong with you, but what happened to you, okay? A lot of this can be really explored through the example of the pelvic exam, right? So a lot of these elements come clear through this. So the pelvic exam is extremely vulnerable, right? The patient is in a vulnerable position. They're laying down, they're on their back in foot rests that can actually be sort of restraining, right? Limit mobility. And then you add to that they are undressed, right? I don't know many people that are their most comfortable when they have their genitals exposed to a stranger, right? Which really is what we're talking about here. We are strangers or near strangers, right? Forget whatever relationship we have or don't have, there are inherent power dynamics, right, between a patient and provider, right? We don't call it white coat syndrome for nothing, right? They're seeking a service from us, potentially more degrees on the wall, whatever it is, right? There are inherent power dynamics. There are a knowledge differential. We're under a crunchy drape sheet, right? All of these things that can make it very hard to feel like an empowered full person, right? And then beyond all of those foundational concerns, there's the exam itself, right? Which we know should not hurt, but certainly can be uncomfortable, right? A ton of pressure, swabs, all of these things, right? So a couple of things I want to lift up. One is you'll notice my word choice throughout this description. So footrest versus stirrup, a drape versus sheet, right? And an exam table, not bed, Okay, we are working hard here to remove any sort of sexualized language from our discussion of the exam space. Okay, because we have to be honest that what we do is intimate work, right? We are caring for people's sexuality, right? And pieces of this exam and of things that we do mimic what happens in people's personal sexual lives that may have happened in their consensual sex lives or in non-consensual abusive dynamics, right? And assaultive dynamics. We cannot ignore the intimacy of the work that we do. Well, it is normal for us, and I may see 30 patients a day, right? It is anything but normal for our patients. And with all of this, I think we can think pretty easily about different activators that could be present in this space. So saying things like just relax or open your legs wide, right? We want to avoid things like that that can be activating. The position itself, being on your back with someone standing over you, could be activating. Pushing someone's legs open. We never want to push someone's legs open, right? We want to use different techniques like saying, you know, let your knees drop towards the walls, or like a frog, or like you're doing yoga, whatever's going to work best to explain that position. Sometimes I'll even put my hands out to the side and say, if you're able to bring your knees to meet my hands, right? So it's giving them that guidance, but I am not moving their legs. They are empowered to move their own legs, right? Okay. Again, we just have to think about how when trauma is linked to healthcare, it can make it harder for people to seek healthcare in the future. So this is one of the reasons why implementing a trauma-informed approach is so important, because we are helping people's sort of full lifetime of health, okay? You know, there are so many healthcare experiences that can be traumatic or closely linked to trauma. For example, coming to the ER after a car accident, or for a rape kit after a sexual assault, things like that. But we can think about things within the world of reproductive and sexual health that, again, as we talked a little bit about at the beginning, can really be traumatic for some folks. So learning about an exposure to an STI, a diagnosis of HIV, we talked about, what about simply learning, not simple, there's nothing simple about it. What about learning about a partner's infidelity, right? When you thought you were in a monogamous relationship, learning about an undesired pregnancy. There are any number of scenarios that could be traumatic there as well. So we want to work on being prepared for a range of responses so that we can help the patient manage to the best of our ability. We want to give people as much power, choice, and control as possible. So what are things we can control, right? Can the patient have a choice between having an exam, doing a self-swab, or giving urine to obtain an STI test, right? I would certainly prefer to look at someone's vulva and vagina if they're having symptoms, right? So that I can see redness, so I can see the character of discharge, things like that. But if it's between getting care and getting testing done and not, someone can do a blind self-swab, right? Even for a wet prep, even for a wet mount, right? Even if I'd prefer an exam, right? So you can, again, discuss risks, benefits, and alternatives. Where are opportunities to promote education and healing, to reassure our patients of normalcy if we can? Is an exam truly necessary for their presenting concern, or could it be deferred, right? Could we use different positioning? Instead of using the footrest, could we use the foot of the table, right? What else could we do, right? How about self-insertion of a speculum? Have you ever tried that or talked about that, right? Patients can actually insert the speculum themselves. How about expedited partner therapy, right? Are we making sure that people understand what's being tested for and what isn't, right? How often have we heard someone say, well, I was tested for everything, when we know that's not true? Have we done a good job explaining window periods, right? When is testing good for? When should they come back? All of this information matters. Are we doing true non-coercive and non-directive contraceptive counseling, right? If a patient wants a LARC removed, right, a long-acting reversible contraceptive removed, even if it was just placed recently, it's their body, right? We are never going to hold someone hostage in this context. Let's also own and acknowledge that there's nothing trauma-informed about meeting a patient without their clothes on, right? Although this sometimes is the reality of our situation, right? I worked in a clinic that had overbooked Q10-minute visits and patients were always undressed when I walked into the room. But if you have the power and are a decision maker in your organization, what can you do to use your power and voice to advocate for other pieces of this? We're going to do a bit of a deeper dive into informed consent quickly. So consent, there's a nurse midwife named Stephanie Tillman who defines consent as a clear dialogue between individuals to engage in a specific activity. Expectations for consent to an intimate examination in healthcare should equal to, if not exceed, expectations for intimate interactions in society. I love that. So consent is unmistakable, often verbal, uncoerced, and freely given. It is reversible. Once it's been given does not mean it can't be taken away. It is specific. So by walking into your office for X, Y, or Z service does not mean they've consented to every possible piece of an examination. And it is informed. We have to also remember that the absence of a no is not a yes. Okay? So unintentional misunderstanding can happen for a million reasons, right? Including, as we've discussed, that what is routine for us is anything but for them. The fact that when people are activated or have that kind of trauma brain on, that we are not taking information in sort of a normal way. It can also, a misunderstanding can also be more common in the face of biological needs or deficits. So someone who comes to you in an emergent state where they haven't slept, where they're worried about food or they're hungry, or where they're worried about how long they waited in the waiting room and they have to get home to their kids or pets or work, right? We have to remember that things can be perceived as assault if the patient does not believe that they have given consent and given consent freely. Okay. We have to think about the full context, their trauma history, historical violence in or mistrust of the medical system, right? As we've discussed multiple times, that can be based on racism, classism, misogyny in healthcare historically, and all of these things. When we think about coercion, again, a quote from Stephanie Tillman, who says that in healthcare settings, actions that would be considered coercion or assault in social settings are often erroneously labeled as clinically or medical legally necessary. Okay, so when we think about consent, we often think about it comes to mind in two ways. One is informed consent around, either your iTunes agreement or medical, right? Informed consent. Or we think about consent in the concept of sex, in the realm of sex, right, of partnered sex. And if you imagine for a moment that someone is engaging in a sexual encounter and they say, "No, wait, stop." And the partner responds, "Just 1 minute, I'm almost done." We know that that's not okay. And yet we see that happen not infrequently in a healthcare setting, right? Perhaps obtaining a pap smear and a patient says, "Oh, that hurts, stop." And we say, "Just a sec, I'm almost done," right? Or in an IUD placement, "I don't want to do this, it hurts." And you say, "I'm almost done." And again, I don't think anyone is ever trying to harm a patient or cause assault, right? Or commit assault. I think we're saying to ourselves, this is why they're here, or, "Oh, they've come so far, we got the speculum in, and really we are almost done." But it doesn't matter. Remembering that consent is reversible and can be withdrawn at any time. If we continue on, just as it would be in a sexual encounter, if someone continues on after the patient has said stop, that crosses a line. Okay, so again, this comes down to a real discussion that we need to be having up front. Around language, around communication, okay? That's pretty overt. We can also think about more gentle or not as obvious situations that could be hard. It's not uncommon for someone to say, well, what would you want, or what would you want for your loved one? And I think we can feel like, hey, we have expertise, and so we're going to give that opinion, right? That's helpful. That's why they're here. But the issue becomes, what if the patient makes a different decision than what we said we would choose or want for a loved one? Are they now going to worry, even though it was a well-intended, gentle recommendation, that now they're worried about our feelings or impact of going against us on the therapeutic relationship? Okay. When we're thinking about language here, I just want to lift up some of the places that you do have power to make change. For example, using the words decline instead of refuse, things like that. Okay. And it has been brought up to me that can have, some institutions have legal guidance on that. So of course, go with whatever your legal guidance is, but think about what it means from an empowerment perspective to say that someone declines a service versus that someone refuses a service and where the agency is. Okay. So this is just pretty brief on kind of some of the bigger organizational pieces to trauma-informed care. My amazing colleague, Alyssa Conklin, a wonderful OBGYN who's actually on the call, brought this quote to me that comes from Sandra Bloom. It says, trying to implement trauma-specific clinical practices without first implementing trauma-informed organizational culture change is like throwing seeds on dry land. Okay, so here are some components that we can put into place, right? Organizational planning, shared decision-making, trainings like this one. We're happy to talk to your organization if you have the time and space for that. Looking at your physical as well as social emotional environment. And to wrap us up and leave a little bit of time for questions, one of the things that is hard about trauma-informed care is that it is not a checklist and boom, now we're trauma-informed, right? So we wanted to put a couple of strategies that can help operationalize this into your minds. Some we've covered a bit before. Again, it's not an order or a prescribed process, but some strategies that you can keep in mind. So one is to make sure that you explain all the steps and equipment before you begin any step. So what to expect, the rationale, the risks, benefits, alternatives. Again, you may recognize this as a lot of the important components of informed consent, right? This calls on the principles of safety, trust, transparency, right? When I talk about place and space, I want to be thinking again about that physical and emotional safety. What does safety in a room look like? Don't block the door. Right? Don't stand between a patient and the door so that they leave, so they have an exit. Do you make eye contact or not? Do you have the ability, like we've talked about, to meet patients while they're still dressed? How else can you promote comfort? Some basics: lubricant, appropriately sized speculums, draping for modesty and comfort. Can they have a support person back with them? How about distraction? Like, can they play music or be playing on their phones, right? I think sometimes we feel offended if a patient has their phone out, but sometimes that can actually be really valuable, right? I really like zoning out to Candy Crush, right? Like whatever it is for that distraction. How about if we're making a phone call? Our time is limited, but it's important that we check in with, are you in a safe space? Are you able to talk? Do you have privacy? Next, permission. We cannot assume a right to other people's stories. They don't owe us a disclosure. We have to earn their trust. We also don't assume a right to people's bodies or stories or even their time, right? So phrases like, with your permission, I'll start the exam, and waiting for them, or saying, let me know when you're ready to begin, instead of saying, okay, I'm going to start now, right? Is now an okay time to have this conversation? Things like that. Again, focusing on empowerment and reassurance, even if it's a circumstance that they don't feel proud of that maybe brought them in, reminding them that they are acting responsibly now and that we're so proud of them for coming in, right? Also thinking about, there's like a conundrum we have around sexual risks, right? Soapbox moment. We take risks every single day for the things that we love every day, right? Any hobby you have has risks. Do you go on bike rides? Do you skydive? What do you do, right? We mitigate those risks. We put on a helmet when we bike. We put on our seatbelt when we drive, but we take risks every single day. And yet we shame people so hard for risks they take in their sexual lives. We take risks for things that bring us pleasure every single day. You know what's gross? Colds. Colds are gross. It means you didn't wash your hands well after touching snot, right? Like, but it happens. It's an established part of normal life, right? Why are STDs so different? Why are STIs so different? They're not. Okay, potentially. All right. Thinking about patient preferences for communication. Well, I've talked about saying all the things and giving all the information. Someone might prefer not, right? So let's also ask and make sure that we know if they want to hear every step or if they want just the basics to like get consent and then talk about the weather or their pets, or let them stay quiet and do breathing distraction, things like that. Okay. And then again, remembering that trust is specifically altered by trauma. But above all, remembering that we must use a shared decision-making model and trust that while we may come with expertise, our patients are the experts of their own lives and circumstances. I have a number of references for you. Here is my contact information. This QR code leads you to the Midwest Trauma Informed Training Center sign-up page. So you can use the QR code to enter your information to hear about upcoming webinars and other trainings, as well as some amazing listening and learning sessions that we are offering so that we can figure out how we can best serve you. Megan, thank you so much. Just put the dates and times for those learning sessions in the chat. We would love to see you there. So again, go ahead and sign up. If you don't like QR codes, you can go ahead and email updates@hct.org to get signed up for that as well. Here are the dates for our upcoming webinars. I mentioned Dr. Alyssa Conklin. She will be giving the webinar on the 24th, which is going to be amazing. We talked a little bit about that mind-body. There she is. Hi. Mind-body medicine webinar coming up in the 12th. And then the 17th will be another case-based learning from Alyssa. Did I say that wrong? The April one, the 17th. I don't know what I said. Okay. Do we have questions, Megan, or could I go ahead and show the video?
We don't at this time, so you can go ahead and show the video, but
Awesome.
the video is playing. If you do have questions, you can submit them through Q&A, through chat, and we can get them answered.
Thank you. Okay, so if people are dropping off, thank you for spending time today with us. So we appreciate it and look forward to more. One of the first projects that MTITC has done is developing this amazing training resource through a series of videos that we are getting ready to launch over the next 2 weeks. So it is my total pleasure to share the trailer for our videos with you now. Maybe. We tested it. It doesn't like us. Okay, maybe not. Ah, yay! There we go. Just slow. Sorry. Can you hear Megan? Trauma-informed care is a whole-person approach to healthcare that acknowledges the impact of trauma on health and is inherently patient-centered. It's care that seeks to create physical and emotional safety for those who have experienced trauma and rebuild their sense of control and empowerment. In this video, we'll have an opportunity to experience a trauma-informed appointment through the eyes of a patient, starting with the moment they walk through the door.
Good morning. Hi, I'm Bev. Do you have an appointment with us today?
Yeah, I think so.
Great. I am happy to get you checked in. I'm just going to need your first and last name and your date of birth. Now, you're welcome to tell me that, or you can give me a photo ID with that information on it.
Trauma-informed care enhances the patient-provider relationship, communication, and overall patient experience, which can ultimately save time by preventing misunderstandings, reducing patient anxiety, and getting patient buy-in.
Before I even call a patient back, I review their chart. I take note of preferences that are documented, like what they'd like to be called. When we're meeting, my first goal is to create a comfortable atmosphere. I introduce myself with my name and my pronouns, giving them a chance to share theirs if they'd like. I match my pace to theirs as we're moving to the next area. When it's time to take vitals, I explain each step and give as many choices as I can. It's all about fostering communication, sharing control, and respecting their boundaries.
How do we really put trauma-informed care into practice? And why should we do it?
It's helpful to listen to stories of actual patients and providers to learn about how significant it can be to experience or not experience trauma-informed care in healthcare.
Seeing myself represented in the spaces I interact with matters deeply. And not just passive acceptance, but active affirmation of all the parts of who I am.
Everyone deserves to feel safe and seen when they're seeking care, no matter what. But for people with a history of trauma, a bad experience can quickly snowball into something larger than just an unfortunate interaction.
Trans people often face indignities, and these are amplified when intersected with race, socioeconomic status, or other factors. One misstep from a provider can elicit a strong response because we're constantly on guard due to who we are.
I've often thought about how my perspective as a male OBGYN has influenced the way I communicate with patients. I don't try to deny that there are aspects of patient-provider interactions that I might not fully understand, but this awareness has pushed me to be more conscious of my language and actions.
Okay, so working in healthcare isn't always easy. Sometimes there are patients or days where it just feels really challenging. Remembering trauma-informed practices, that fundamental switch from what's wrong with you to what happened to you, really does make those times better.
So that is the preview of the videos that are forthcoming. They will be freely available that anyone can use in their trainings however they would like. And we'll roll out some information on that, on some ideas on how to use them as well. But we are so excited to be providing that resource to anyone and everyone. So feel free to shoot questions on that our way. Follow us on social media to see the release. And also if you sign up for the MTITC listserv, you will get the links emailed to you all as well. Cool. Any other questions, Megan? Anything else I can do for anyone today?
Nope, I'm not seeing any questions.
Okay.
We still have 3 minutes, so if someone does have a question, they are free to ask it. But while we are just waiting, if there are any questions, just to allow that time. Like I said at the beginning, if you are wanting to receive nursing contact hours, the form to complete will be sent to you via an email following this webinar, along with the evaluation. Both things are needed in order to receive those contact hours. And all of the information of where you send that form to is also on the form itself. So there shouldn't be any confusion on where that is going. I've put a link to the evaluation in the chat as well, just if you wanted to click that open right now and fill it out. Your feedback is appreciated by HCET. That is how we move forward on our webinars and our events to make them accessible to you all and give you the information that you need. Yeah, and I don't see any questions. So Kara, thank you so much for a wonderful first webinar of the year and first webinar of the Midwest Trauma Informed Care Center webinar series. Like Kara said, there will be a few more coming up in the next few months, the next one being on January 24th. And I believe it's at the same time, 12 to 1:15 p.m. Eastern time. And registration is out for that. You should see information more about that coming up. But yeah, we appreciate your time, Dr. Kara, and everyone who joined. And with that, thank you so much.
Thank you all. Take care.